All right, everybody. Good afternoon, and welcome to Engel Rounds for March. Before we begin, I want to make the usual announcements, especially for people on Zoom, which is if you're on Zoom, your cameras and microphones are off, which is by design. We hope you may have questions or comments. Please send those through the Q&A box at the bottom of your screen, not through the chat, which is reserved for the interpreters and panelists. And then you'll see a QR code and an email with or a link, and tomorrow an email with a link for the evaluation, and please do that today or tomorrow. Also, if you're in the room and you have a question, please get up and go to one of the microphones on either side of the room, so everybody can hear you, including the people on Zoom. All right, so now for today, this is the first ever residents roundtable. So, for Engel Rounds, we usually have junior faculty, but there's been an interest growing for a while among residents to be able to present their work. We thought it was a good idea, and so we're using the Engel Rounds to do that this year and probably every year, assuming today is good. Okay, so it's my pleasure to introduce the 4 residents who volunteered to get up in front of the whole department and present their work. We'll have Sungsu Lee, and this is the order of presentation. Dr. Lee going first, then Henry Philofsky, and then Grace Rowe, and fourth, Nilsa Ricci. And all right, so we have 4 good presentations, all on very different topics, and let's give them a nice welcome, and hopefully there'll be a good discussion at the end. Take it away.
All right, thank you, Dr. Silverstein. I really want to say thank you again for the Grand Rounds Committee and Dr. Silverstein for allowing the residents to present. And I really hope that this will be the first of many to come, because there were many residents that were interested in presenting, and not every resident was able to be represented this afternoon. So more to come for next year. And the title of my talk is Novel Program for Cross-Training Between Psychiatry Residents and Law Enforcement Officers. And this is my learning objectives. I'll just get straight to it, to my outline. I want to introduce you to the idea that currently we have a system in which our patients have interactions with law enforcement routinely, and that we as psychiatric trainees have very little exposure to this part of the patient experience. I'll discuss our efforts to broaden this experience and draw my conclusions at the end. So this is an example of what the CPEP board may look like. And I swear this is not the real board. We don't actually have 500 patients waiting to be seen. This is from the EPIC training environment. But I wanted this up because I want to introduce this idea that our patients are brought to the hospital in a crisis, and they can wait for a really long time before they're evaluated. And looking at the data from our own CPEP going back to 2019, the majority of our patients consistently present to the hospital involuntarily under mental hygiene transport. And this is a process that often has involvement of law enforcement officers. The mental hygiene law in our state allows law enforcement officers to initiate the transport of patients to the hospital. And it's written even into the mental hygiene law that it is the duty of police officers and peace officers to assist in taking into custody and transporting people in crisis, even if it's initiated by mental health clinicians. And we don't have the best data on how often this happens. This is a recent review that looked at the proportion of 911 calls in which this is related to a mental health crisis. And the estimates are really all over the place, anywhere between single digits to up to 33% of, this is the estimate of emergency calls that are related to mental health crisis. And unfortunately, there have been really tragic outcomes in this emergency response. I don't have the specific data to share with you, but if you look at news articles, we know that there are cases in which police respond to a mental health crisis and ends up with the patient being deceased. And we have certainly efforts to involve mental health professionals to respond to mental health crises. And we have this in our own department with the mobile crisis team. We have the forensic intervention team in our county, and we have other examples in which clinicians respond to emergency calls. However, there's been no efforts to document or publish any reports of psychiatric trainees being involved in this 911 emergency response to mental health crises. And this is the gap that we have for psychiatry residents. Right now, we don't really know the experience that our patients go through when they're brought to CPEP. And by the time that we evaluate patients in CPEP, it can have been many hours since the initial moment of the crisis. And we miss out on getting collateral from the firsthand witnesses to the crises. And lastly, there's really no way to provide any feedback or education to those individuals that bring our patients to the hospital. There's also gaps that exist on the perspective from the law enforcement side, that what happens once a patient is brought to the hospital is really a mystery, and there's very little understanding of the treatments that we can provide here in a hospital setting. This is despite the fact that law enforcement officers have psychiatric needs as well. A recent meta-analysis found that there's a significant point prevalence of mood disorders, anxiety-related disorders, trauma and stressor-related disorders, as well as substance use that law enforcement officers face. And yet they have significant barriers that they face when they're trying to seek help for their mental health needs. And a recent scoping review found some variety of reasons as to why that might be. So this is my project. This is a voluntary experience for senior PGY3 residents to participate in a ride-along experience with members of the Rochester Police Department. Last year, out of the 7 eligible PGY3 residents, 6 participated, and this year we have 5 that are slated to participate. And this program includes a pre-ride-along survey, an organizational introductory meeting with a senior member of the Rochester Police Department, the actual ride-along experience itself, in which the resident is paired with an officer of the Rochester Police Department, and then followed by a post-ride-along debrief and a survey. The results of the pre-survey is this, that we have very little experience with law enforcement. None of the residents that participated in the survey had any experience with a ride-along. Very few had either personal or professional interactions with law enforcement officers, though all of us reported that we routinely read the reports that come in with our patients in CPEP. Some of the experiences that the residents got to have are really varied. Some of them included mental health calls related to suicide attempts, suicidal ideation. We had a paranoid individual. Some of these individuals were transported to the hospital. And then they were able to witness other calls in the community as well that were unrelated to a mental health concern. These are the results from the pre and post survey, and due to the small number of the participants thus far, I can't make you any specific statements about these results. However, there are some themes. The first question was regarding whether responding to mental health emergency calls are challenging for law enforcement officers, and this is the expectation of the resident. You can see that pre-survey, everybody agreed, and then there was some more neutral responses after the ride-along. The second question was related to whether the expectation by residents was that law enforcement officers face difficulty and confusion in responding to mental health crises. Pre-survey, everybody agreed. there was one after the ride-along experience that disagreed. The third question was whether being a recipient of a police call can be a difficult, confusing, and dangerous experience. Before the ride-along, everyone agreed with the statement, and this is more neutral after the ride-along. The fourth question was related to whether the expectation was that police officers show empathy during encounters with individuals with mental health concerns. There was some disagreement before the ride-along, and then after the ride-along, it seems that everyone agreed with the statement that they showed empathy. And lastly, the question was whether this is a useful experience to have during psychiatric training, and everyone agreed with the statement even before and after this experience. And next steps are that this is an effort that is just beginning. We have more residents that are slated to participate in this experience, and we had the introductory meeting with a senior member of the Rochester Police Department, and we're right now in the process of scheduling these experiences for this year's cohort. And this is part of a wider outreach we have planned for the national audience. And recently, this is something that we feel very passionate about as residents, and fellow residents Grace and Chloe and myself recently published a series of articles for the APA newsletter highlighting the need for greater collaboration with those that respond to mental health crises. And I'd like to conclude by stating that this is a work in progress. And what I can state is that the residents who participated found this to be a valuable experience. And there is a real gap in us understanding the experience of our patients and concerns about the emergency response. And this is an effort to open the door for greater collaboration and influence so that ultimately we can improve the experience for our patients. And with that, I'd like to thank Dr. Weissman for his guidance and mentorship, Sergeant Gallagher of the Rochester Police Department for agreeing to have us participate, the individual members of the Rochester Police Department, and the residents who have participated. Thank you very much.
The work that I'm going to be presenting today is something that I've been working on in some capacity for about 7.5 years. And it's based on a manuscript that I'm currently writing. And I just wanted to include all the authors at the beginning because usually I don't get the time to get to the acknowledgments section. And so I wanted everyone to see who's involved first. What? I'm not used to that level of luxury. So I just want to start by talking about basketball, because basketball is actually where this study came from. Some people play pickup basketball, some people play organized basketball in a rec league, some people play in professional leagues. And the big difference is whether or not the people who are playing together have played together before. And there's a spectrum there. And the idea that we had was to study how differences along the spectrum of people having worked together before affects the ways that people work together, but from a bioinformatics perspective. So the spacing got changed. It's not supposed to be right-oriented, sorry. So our goal was to try to assess whether more opportunities for collaboration between care team members measured through past shared patient volume is associated with reduced mortality and length of stay. So for hospital clinicians who are treating a patient, how many patients, we wanted to examine if the number of patients they treated together in the past affected people that they treat in the future. But to measure this at scale, we can't actually measure people's collaborations. We can only measure their involvement in cases at this time. I'll say more about that in a minute. We used logistic regression for mortality, Poisson regression for length of stay. And this study was based at the Geisinger Health System in northeastern Pennsylvania, in a kind of a research informatics unit that's situated within the business. So it's not grant funded. It involves about 4,000 participants, all adults admitted with heart failure into the adult inpatient units at Geisinger, excluding people who were admitted for planned procedures. And heart failure was identified by a diagnosis code, which is not the best way to do it, but it's what was available. What we study specifically is for the teams of clinicians that documented involvement in patient care within the first 48 hours of admission, the average and clustering of their past shared patient day volumes over the previous 90 days. I will describe that in more depth. And then we looked at, as I said, inpatient mortality and length of stay. So this algorithm is something that I actually wrote myself and then worked on with a software developer, and it's the only thing that's ever been cited from this work so far. The first thing that happens is when patients are admitted, there are people who write notes within the first 48 hours. Those are the people that we are counting as on the care team. Not because the people who come after that don't matter, but because the longer someone's in the hospital, the more people there are, and the problem becomes much more complex very fast. Also, the people who see someone immediately have a huge bearing on how the case goes. So that's the medical team. Then we go back 90 days and see how often any of those people have written notes with those other people on the same day. We can't guarantee that they talked, can't guarantee that they messaged each other, even looked at each other's notes, but it's possible. It's an opportunity for collaboration. And then we can roll that up into a social network graph that enables us to do social network analysis for each team. So to return to the basketball analogy again, in basketball, you could look at the average number of past shared minutes on the court for the starting 5 players. You could also look at the degree of cliquishness of those past minutes on the court. So are those minutes clustered within a smaller group of people, or is it spread evenly among the team? In the hospital, we can look at the average past shared patient day volume, and we can look at the clustering of that patient volume. And that maps on well to 2 concepts of social network analysis that are well validated, and that's the network density and the average weighted clustering coefficient, which capture each of those properties. A key part of this research is risk adjustment, because the outcome we're going for is mortality, which is quite rare. And so the risk adjustment is really what enables the statistical power in order to do this analysis. So we looked at demographics, as well as factors that relate to acuity in some way when the person's admitted, where they go, whether they're on a cardiology specific unit, because we're looking at heart failure patients, and then if they have a DNR order. The secret sauce, as it were, is the actual risk scoring. We used the Charleston Comorbidity Index, and then we used what we call the LBS, which is a dynamic lab score that's based on a CBC, a BMP, vitals, and some other stuff. And it updates every day for every patient in Geisinger on an ongoing basis, which means that we have for all of these patients before they're in the hospital and after they're in the hospital, we know their risk of mortality, and it's very, very well calibrated, which gives us a lot of statistical power. And we also look at team size, because that's a part of the equations to measure things in the social network analysis concepts that we're measuring. One important thing I wanted to touch on quickly is that we are looking at this as essentially a natural experiment, because at Geisinger, the process of assigning patients to teams is not something that you can do while paying attention to the amount of experience teams have working together. And there are reasons for that. Mostly because there's a standardized process that drives bed allocation that doesn't depend on who is staffing the bed. And there's no visibility into that, which essentially means that it's a quasi-random process, which enables us to do a slightly more rigorous version of inference. It also takes a lot of data to do this calculation, and none of the people who work at Geisinger, aside from the technical team that I work with, has access to it. And also because team members are assigned to patients after they get to a bed, not before. So it's just temporarily impossible to get the confounding. descriptive statistics. The thing I want to point out is the predicted mortality score at the bottom, the 30-day mortality is a percentage. So for these patients, on average, they have a 76% chance of dying in the next 30 days. And it's a very well-calibrated score. So it's a very sick population. And the teams are also quite large. So in the first 48 hours, 18 people on average were writing notes, sometimes up to 26. And these were the results for mortality and for length of stay. So all of the odds ratios are below 0. All of them are statistically significant. The effects of average pastured patient volume on mortality and length of stay is smaller than the clustering, which is interesting because the clustering of pastured patient volume is a relative metric. It doesn't take into account the absolute volume of experience that teams have working together. But it actually overpowers it. When you put them both in a regression, the amount of clustering overpowers the average shared past patient volume, which essentially means it looks like the effects are being driven by a small number of people who work together a lot within the people who see someone in the first 48 hours. As I said, the effect was protective for both metrics. And we believe that essentially the quasi-experimental setting affords us a conditionally causal interpretation of this association. And it's also kind of awesome because it's using metadata of notes that are generated all the time, every day, and it has enough of a signal to power a mortality analysis, which is awesome and kind of rare for health system bioinformatics research. A lot more work is required, mostly because we don't know how these people actually collaborate. We just know they wrote notes on the same day. And there's a lot of work to be done there. In the last 30 seconds I have, I'll go through the limitations quickly. Mostly, this was one health system. We didn't adjust for chief complaint because it wasn't available for all the days, or all the patients that we had it for. Our heart failure characterization was minimally informative, and confounding as a possibility. But I will say that we actually did replicate this at Geisinger with an additional 5,500 patients. And we worked with a team at University of Florida who also were able to replicate this finding in the ICU. They were not able to replicate it in their overall population, but they did not use as intensive a risk adjustment method as we did. So yeah. All right. We have more confirmatory analyses to do. And currently there's an R01 under submission with the University of Florida team, the Geisinger team, and with Dan Mang here, some other people. So hopefully this work will go somewhere. There you go. That's all I have.
Good afternoon. My name is Grace Rowe. I am one of the fourth-year residents at the U of R Psychiatry residency program. Today, I'm going to share about a project that I've worked on since my second year of residency, and it's called Establishing a Sustainable Medical Student Mentorship Program Involving Psychiatry Trainees, which includes residents and fellows. So to start things off, the number of students who are matching into psychiatry residency continues to go up every year. So if you look at this graph, this was published by the NRMP in 2023, and even just since 2017, at least 60% increase in US MDDO spots are being filled and created. Now you would imagine, if you think about your own careers, your own paths to where you are today, mentorship is really important. So I looked into various resources to see what kind of resources are out there in terms of how to provide mentorship. There's lots of studies that kind of verify that mentorship for medical students is really helpful. but they're primarily regarding like advisory, dean, level of support, or very focused research contexts. There's really limited guidance, actually none at all, about how to actually build a mentorship program that involves medical students and trainees of a specific specialty. So this was a collaborative effort. I worked closely with the medical student Psych Sign Interest Group, which is led by Dr. Cardella, who's also the clerkship director, as well as our residency program, who at the time was led by Dr. Nichols, our program director. And we created this mentorship program and with the goal of connecting medical students of all years, M1s to M4s, including those who are taking gap years, research years, to current psychiatry residents from PGY1 all the way to PGY5, including fellows of all the different subspecialties. My role as the liaison was to communicate between the two groups and also to collaborate with the M2, one of the leaders of the interest group, just to keep an open line of communication. Now, as you can see, this is a little bit of the introduction to the sign-up form, and I kept it pretty open because, again, we never had a program like this before, and I was curious to see kind of what would happen if we created one. So the only expectation was that you would sign up, you would get paired with a mentor-mentee, and the expectation was to meet once a month. Whatever you choose to do at that time or what you talk about was really up in the air. So as the year went on, through conversations with my peers, with students, I began to notice that there's a lot of variability in the mentors and mentees' experiences. So Dr. Cardella and I, we submitted an IRB. This project was actually IRB exempt to get some feedback and do some quality improvement for the next iteration of this program. So this is the general timeline. So the program started October 2022. And then about halfway of the year, towards the end of that academic year, actually, we actually sent out a survey, anonymous survey to the students and the mentors. And I asked a variety of questions. There were 37 participants, which is really awesome. And it kind of shows you how much mentorship is desired, as well as, you know, the number of residents and fellows who were offering their time to be involved. I asked questions about, you know, how often did you meet in the past 6 months? What were some barriers? What did you guys talk about? And also, were you satisfied? Was this a worthwhile project or experience? And I also asked for some feedback about how can we make this better for the next group. I asked a variety of different types of questions, and I did use the RedCap platform, which was really helpful to kind of keep everything organized. So afterwards, we consolidated the data, made some changes, which I'll share in the next slide, for the next round to start at the end of 2023. So we had at least in my opinion, a pretty good response rate of over 56%, and representative of that group was more than half of the mentees and more than half of the mentors. Now, 85.7% said they could only really meet about once every 2 months, not the recommended or expected monthly meetings. And the reason for that was largely due to scheduling conflicts. In terms of what they talked about, medical school advice and residency advice were very much at the top of the list. The majority of respondents said that some sort of reminder or check-in would have been helpful for consistency and accountability. 90% of mentees were very satisfied with the mentorship provided. 90% of mentors felt that they could either usually or always provide mentorship or support as was appropriate. At the same time, the majority of mentors also wanted a little bit more guidance. Like, well, what does it mean to be a mentor? Am I doing this thing right? And also, what's the difference between being a mentor and just being a friend or a peer? So with this information, we implemented some changes for the next year. Number one, I decided, we need to make sure that there's no role confusion. If you all think about times you were paired with a mentor or mentee in another program, how often did you kind of pause and ask, is it my responsibility to reach out? Or if my mentor is not reaching out to me, are they too busy? And then eventually nobody makes contact. So we decided, let's make the responsibility that of the student. And so in the sign-up form for the next round, I include a little blurb here that was required that basically says that I am committing to reaching out to my mentor every month. Now, I did provide a lot of reassurance saying that the residents and fellows are signing up for this, committing to this, they're interested, like they are waiting to hear from you. The second change is that we were able to incorporate a didactic hour led by Dr. Cardella. And she talked about kind of what is mentorship. And these are just a couple slides that were in her presentation. All the residents attended, and it was a nice discussion about kind of what are we expecting, what is our role, how do we do this thing? And then the third change is that my role was every month I sent an email to all the medical students that were mentees as a reminder to check in. Now, a few updates since then. It would not be a true research presentation if I didn't share some of the downsides, which is I did send a post follow-up survey and the response rate was 0. So with that, you win some, you lose some, but it did lead to, a lot of discussions with my peers about, okay, what are we doing that's wrong here, right? Like, I had to process that a little bit. And what we realized is maybe the scope is just too big. We went from nothing to trying to do everything. So instead, we decided for this coming academic year to really focus on mentorship for M4 students who have already or are very close to deciding to pursue psychiatry residency. This would be a much smaller cohort, but it would also be perhaps more meaningful, more relevant, more productive. Then you may ask, how about the M1s or 2s or others who are, taking gap years? Well, perhaps we can really focus on just providing opportunities for them to network and kind of meet in larger settings. Here are just a couple photos. Dr. Cardella, shout out to her for hosting a mixer every year at her own home, which is open to faculty, residents, fellows, students. And these are moments that, again, less commitment, low pressure, just a way for students to kind of get to meet people in our department. In terms of additional future directions, so my co-resident Sungsu and I, in collaboration with Dr. Cardella, Dr. Pulley, Dr. Lee, and Dr. Fu as well, we are working on developing a proposal for an educator-teacher pathway. And the reason that I bring this up is because one of the core pillars of being a teacher, being in academia is being a mentor. And that can be academic mentorship, research, professional. So I'm wondering, perhaps this can be one of the electives or maybe one of the requirements of those who may decide to pursue this in the future. So with that, just to wrap things up, I just want to give a big shout out to my faculty mentors. So Dr. Cardella, Dr. Pulley, who has kind of been my individual education supervisor, and Dr. Nichols, all for your support in this endeavor over the past few years. I also want to give a big shout out to Armand, who I believe just matched. So I think he's finishing up his medical school year. I believe he'll be doing internal medicine. And then Tessa, one of our own interns, and Simran, who is now a psychiatry resident at the University of Pittsburgh. They were very helpful in a lot of the background reviews that I was able to represent on the group's behalf at various conferences. And then a big shout out, of course, to our residency program and our department for the support and interest in projects like this. And that's all I have for you. Thank you.
Okay, today I will be presenting the quality improvement project titled Understanding and Reducing URMC Spanish Interpreters' Vicarious Trauma. Okay, so patients with limited English proficiency experience disparities in health outcomes when compared to patients with English proficiency. Imagine being hospitalized, having limited ability to communicate your concerns to providers, having limited understanding of what providers are saying and doing, getting discharged with instructions written in a language you don't understand, and then getting a big hospital bill. If this were your experience, then it should come as no surprise that you would be at high risk of having a poor health outcome. Per Section 1557 of the ACA, hospitals receiving federal financial assistance must take reasonable steps to provide meaningful access to individuals with limited English proficiency. After English, Spanish is the most spoken language in the United States. URMC Spanish interpreters are linguistic and cultural specialists who are consulted for all patient and provider needs. They provide language access, have an office at Strong, are available to provide in-person services 24/7. They work with patients during their happiest moments, their saddest moments, and everywhere in between. They work with providers to communicate clinical information accurately and with cultural sensitivity. Afterwards, Spanish interpreters document the session in the patient's medical chart. I started working as a Spanish interpreter at URMC during my medical school years. I noticed that I was experiencing secondhand trauma as an interpreter that I was not experiencing as a medical student, despite seeing similar clinical cases at the same institution. I wrote a personal narrative of my differing experiences working as an interpreter and provider in an article titled, "Don't Mute the Messenger." Spanish interpreters are different from other healthcare professionals in that they process and relay information in the first person. For example, instead of saying, "The patient's mother is asking if her baby is dead," interpreters ask, "Is my baby dead?" Spanish interpreters regularly experience other people's perspectives in two different languages. In Spanish, adjectives must have the same gender as the noun it describes. This grammatical process does not exist in English. When speaking in the first person, interpreters change the gender of adjectives in Spanish to match the gender of the English-speaking provider. In doing so, they help patients and providers build rapport through direct communication. Research shows that the use of third-person pronouns in self-talk lowers the activation of brain areas involved in processing emotions related to the self. This makes sense because we typically use third-person pronouns to refer to other people, and we typically use first-person pronouns to refer to ourselves. When interpreting, boundaries between self and non-self may become blurred. This makes preparatory and debriefing sessions crucial for interpreters. This QI project aims to determine how Spanish interpreters define trauma, if they experience trauma without formal debriefing, and how a debriefing protocol can be improved if needed. I asked 60% of URMC Spanish interpreters 4 open-ended questions. 10 participants allowed me to record their interview, and 2 participants provided written responses. The interpreters' interview responses were qualitatively coded, and recurring themes were identified. Quotations taken from the transcripts have been stylistically altered to minimize the risk of participant identification. Question 1. As a URMC Spanish interpreter, what is your definition of trauma experienced in the healthcare setting? Spanish interpreters collectively defined trauma as an intensely emotional or physical event occurrence for which you felt helpless and unprepared. That is distressing, stressing, disturbing, shocking, sudden, and unexpected. And although it makes you disregard your own feelings to maintain objectivity in the encounter, it still impacts you, affects you, shakes you to the core, and sticks with you. Question 2. While working as a Spanish interpreter at URMC, have you ever experienced trauma? Almost all participants said yes. Some examples include seeing a patient die or being with a patient shortly before they died, especially in pediatrics, breaking bad news, especially to family members and when it's done in a culturally insensitive way, interpersonal conflicts with patients and/or providers, for example, having to interpret rude remarks, patients recounting traumatic events vividly, and being expected to console family members in an emergency. One interpreter said, "The providers just put me behind the curtain with the patient's family member, and they left me there. I didn't know what exactly was going on." Another interpreter said, "You feel helpless, and you experience the anguish of the situation, of that person, and there's nothing you can do about it. I didn't know what to do, no direction from the provider at all." The impacts of trauma include avoiding eye contact with devastated patients, crying, inability to continue interpreting without a significant break, projection of patient experiences onto loved ones leading to arguments, insomnia due to rumination, and feeling uneasy during similar situations. Question 3. Debriefing is a group meeting during which clinical events and decision-making are reviewed and discussed to improve clinical practice. Have you ever debriefed after experiencing trauma at URMC? Less than half of participants had debriefed at least once with the healthcare team. However, these were only after a patient's death, and they could not always debrief even after a patient died. Remember that a patient's death is only one form of trauma experienced by Spanish interpreters. Of those who participated in a debriefing, all felt that it was helpful. One interpreter said, "Debriefing helped big time. After you hear so many people feeling the same way that you felt at one point, it relieves you a little bit. the whole trauma that we went through where we tried to help but couldn't, we came to the point where we understood the whole situation and tried to apply it to similar conditions in the future. Question 4, is there a debriefing need that is not being met? If so, what does ideal debriefing after trauma look like for you as a URMC Spanish interpreter? Almost all participants express a debriefing need, and all suggested improvements, such as being invited to all formal debriefing sessions with healthcare teams, having a short pre-session with providers before interpreting. One interpreter said, maybe because of the pre-session, I was prepared, so the news wasn't so impactful or so traumatic for me to hear. Having a short post-session debriefing with providers after interpreting. One interpreter said, post-sessions are invaluable because even if you're saying, we did well, you are establishing rapport with the provider and you are letting the provider know that we're working well as a team. And if things didn't go well, then let's highlight this point so we can improve. Even 30 seconds works. And having interdisciplinary educational sessions. One interpreter says, when it comes to trauma, we should be proactive. It would be helpful to have these sessions before we actually have to deal with the situation, because then we have all the tools to handle it. Another interpreter said, more education can make the interpretation easier, and it would be a way for Spanish interpreters to help advocate for Spanish-speaking patients who need a lot of education. Daily huddles were incorporated at the end of each business day, where Spanish interpreters meet to share patient updates, discuss challenges they experienced, and provide handoffs to interpreters working the evening, overnight, and weekend shifts. Interdisciplinary educational sessions were implemented to increase Spanish interpreters' knowledge about various areas of medicine. In summary, patients with limited English proficiency are human beings who are proficient in a different language. Spanish interpreters help reduce disparities in health outcomes among Spanish-speaking patients through language access. Nearly all interviewed URMC Spanish interpreters had experienced vicarious trauma, yet debriefing is not standard practice. We should help protect the well-being of our Spanish interpreters. Key changes to clinical practice that could help reduce URMC Spanish interpreters' vicarious trauma include having a short pre-session with the interpreter, having a short post-session with the interpreter, inviting interpreters to all formal team debriefings, and expanding their educational opportunities. There's a lot more work to be done on this topic across other areas of interpretation, across other languages, and at other institutions. Here are my resources, and I would like to give special thanks to everyone involved in this project.
All right, well, thank you all. If you could all come up here now and take a seat in the front. We'll take questions from people attending via Zoom and also here in the audience. Remember, if you're here, to use one of the microphones in the aisles. So I just want to say first, that was really enjoyable. I wasn't really sure what to expect. And I think I speak for everybody. Based on some text messages I got, I think everybody really enjoyed that. And yeah, it was really nice change to have, 4 talks like a conference format and to learn about what the residents are doing. So thank you all. And I think they were all really good presentations and really appreciated the timing too. You guys were like so precise. We're not having to rush through anything. Okay, so thank you again. And having said that, would anyone like to ask the first question? Oh, here we go. Sorry, Tara.
Hi.
But if you go to the mic, I will call on you later.
I am a peer advocate on CPEP, and I just want to go back to, I don't remember how to say your name, but the person who did the law enforcement and residents project. And I think that's awesome because I sometimes see people come right off the elevator onto CPEP and they are very unhappy about being there because they've had a mental health arrest. And one of the things that really helped me was also going on a ride along with the mobile crisis team. And I was wondering if that might also be something that would be helpful. I haven't gone on a law enforcement ride along, but I really would like to. And after hearing you, I'm going to ask my supervisor if that might be possible.
Yeah, thank you for the comments and the feedback. The PGY1 residents this year are riding along with the mobile crisis team, and that is a very valuable experience, and we've had, I think, great feedback from the PGY1 class. The main difference between, I think, the law enforcement response and mobile crisis response is that law enforcement, that's the responders when you call 911.
Right.
Those are the folks that are going to the really, really emergent calls. And I think that is a different perspective than some of the calls that mobile crisis teams respond to. And I think they're both really valuable, and I think those are complementary and different experiences. So thank you for that feedback.
Thank you.
And Sungsu, we have another question coming in over Zoom. What does the ride-along entail in terms of time, the role of the resident, and is the resident more of an active participant or a passive observer, or both?
So ride-alongs typically involve with the it's an observer role. So the observer goes along and essentially shadows the role of a police officer. And in our role, we spent anywhere between a couple of hours to the entirety of a shift with a police officer, depending on the schedules. And our role was really in an observatory role. We weren't there as psychiatrists necessarily in that role, though we do have that expertise and we do have those conversations with the law enforcement professionals as we do the ride-alongs.
This is very low. Just want to point that out. I want to take a step back because my questions are also for Sungsu, and I just wanted to say that, you know, it's such a thrill actually to be able to hear from each of you, having worked with you for years, hearing about what you've been up to. So I hope we continue this in future years. Okay, Sungsu, back to you. I'm curious about two things. One is, are you collecting any qualitative data on the experiences? And if not, is that something you would consider? I would encourage you to, in terms about, you know, how are the residents, just real-time feedback qualitatively. The second question is, do you know if there have been any discussions about extending this opportunity to other interdisciplinary training programs?
Thank you, Dr. Augustine. So we do collect qualitative feedback, and I didn't share that with the group today based on timing, but it is really interesting to hear directly, not only from the psychiatry residents, but also direct feedback from the law enforcement officer perspective as well. And I think the overall theme is that this is something that is relatively new for folks and is a unique experience. So I'll be able to share that with you next time I talk about this. And it's a good question about, you know, other disciplines participating. I think for right now, this is again the first step, and we've really limited to senior residents in psychiatry, given the gravity of the ride-alongs. But it's something that I hope will lead to greater collaboration, you know, in not just within our psychiatry residents, but also other trainees as well.
Okay. I'm going to take some questions from Zoom, and one question, and then we can get to Sephora. So Nilsa, the comment came in from somebody that the person who wrote this saying they never had formal training working with interpreters. I don't think any psychologists, psychiatrists, social workers, you know, do. So what's the best way to make that happen? On-the-job training, or make it part of formal, you know, formal training before people get their first jobs? Do residents receive any structured training in how to do that?
That's definitely a very important question. So I know in my path, there's like a small training from that perspective, but it's different to get a training at the beginning versus a more, how does it actually fit into clinical context? So I personally got a little bit of training in medical school. We had seminars at the very, very end of my fourth year here. we didn't really go into depth in terms of pre-session, post-session, or like, it was more so speak in first person kind of training. Look at the patient, don't look at the interpreter kind of training. I feel like nowadays it would be very helpful to have educational sessions in our residency program specifically to kind of talk about the pre-session, post-session, how to interact and how to work with interpreters, because they do have a lot of information to provide, especially when it comes to like the mental status exam, where part of it is like, what's the language like? What's their speech like? How does it change day by day? And those are questions that if we don't speak the same language, we really can't be commenting on those types of things. So I think especially it's important to have something like that in our program here. And then of course, if we have an interpreter just kind of working with them and doing a pre-session there, just kind of, hey, this is a patient, just let me give you a little bit of background. What are we gonna do here? What are some of the goals? Are we just rounding? Am I gonna break bad news? Are we gonna talk about a new medication? That kind of thing can really help, and then also just kind of learning as you go too. The interpreters are very good at also expressing what they need, but also like as providers, it's important to loop them in as part of the team.
Thanks. Sephora?
Just for the record, this microphone is perfectly sized. I would also like to say I am not surprised by what we experienced, but I am very grateful. I did have an expectation that it would be pretty close to this, but I am impressed with, as Dr. Silverstein mentioned, the precision, the focus, and the import of your work. So one of my favorite features across each of your presentations was that in the midst of your training, whether it was as a resident or a medical student, but as a member of our psychiatry community, that you were able to both focus on what was happening in the here and now as you're learning, and to focus outwardly on the patients and communities we serve, on the people that we're serving with, on the people coming up behind us, and the people who ultimately are going to drive healthcare outcomes here in our own system. So I'm just very impressed with the collaborative spirit reflected in all of your projects, and you guys rocked it. So thank you.
Okay, question for Henry. So you were showing essentially better outcomes when people have an experience of working together on.
When they write notes on the same patient on the same day. I don't know if they're working together.
Okay. So I guess the question is about the mechanism of how that works, right? Because you'd want to know, not just as a statistical relationship, but why that is, and then maybe use that to improve the function of teams or the effectiveness of teams. So, I mean, it can't be the process of writing the notes themselves, right? So what is it about that is associated with the better outcomes, in your opinion?
So the writing notes is just a signal that people are working on the same case. It's nothing special about writing notes. There's lots of research on people working together more often having better outcomes in fields outside of medicine. And it tends to be the things that makes teams work well everywhere, which is having common goals, shared mental models, ways of communicating, ways of getting feedback, and things of that nature. But I would also, in response to that question, you can teach people to collaborate better, but that actually wasn't the purpose of this study. The purpose of this study was from a business research unit looking at structural things the business of the hospital could do to improve outcomes. And one of the things that like the business can do is structure work schedules to have people together more often. And it's a specific choice that is less economically efficient. And so it was a question of whether or not doing that could potentially help outcomes. And at least at Geisinger, in their data, the answer seems to be yes.
Thanks.
I have a question for Nilsa. My name is Jordan Koch, and I'm a psychology doctoral intern that works at Las Fuertes. And so I greatly appreciated your talking about the interpreters. Those of us who work there have the privilege of speaking both languages, and so we don't often use those services. However, that experience of having to code switch, that cognitive load, the vicarious trauma has been something that I have heard talked about where I come from in New Mexico in the borderlands, where there's just a scarcity of these providers. And so I was wondering if in future collaboration, there would be opportunities to kind of promote some interdisciplinary or some collaborations between like Lazos Fuertes and the interpretive services to provide some of that support group and guidance, because I didn't hear in those pre or post sessions their preference of which language they would like that to be facilitated in, but my mind automatically went to Spanish. So I was just wondering what your thoughts on that might be.
Yeah, so that's definitely a great big point. And Lazos Fuertes is, I mean, we're very, very lucky to have like bilingual providers there. So definitely vicarious trauma is something that can be experienced by a lot, even if you're speaking in the same language. But in this case, it's kind of like the pre-session, we would like it ideally to be had with the provider who would only really speak English, unless of course they're in Lazos Fuertes and we're called to interpret for, let's say, a staff member who does not speak Spanish, and then there's in the room a provider who's bilingual, then that pre-session could happen in Spanish or in English. The post-session is something that is, I think, more rare, especially in the emergency room or in clinical context, because physicians just kind of like run out and then a different provider like runs in. And so the interpreter is kind of stuck there and it's like, uh-oh, I had follow-up questions and now this person's gone. I kind of just secure chat them and I'm like, you thought you left, but no. So I just like ask my questions after that. But it would be really great to have like a sort of connection too with Lazos Fuertes and interpreters so that there could be like debriefing sessions that could happen, like a more collaborative effort, because like providers at Lazos Fuertes are experts in mental health, and Spanish interpreters are cultural experts too, in a whole bunch of different like subcultures. So it would be really fascinating to have that connection, and that could help with like pre-session, post-session debriefing, how to advocate for those things, because I do think that interpreters would benefit from like help advocating for themselves too, especially in a very busy clinical context.
Thank you so much.
Okay.
Hi, so I'm Patricia, the educator for the Spanish interpreters. Thank you for this presentation. Thank you for being a champion for us. This question intrigued me, what you're saying, because I think it opens some possibilities. We have many new communities that are coming here, and one of the things that interpreters do is glean from the culture to try and give our providers a cultural context. That's because we're familiar with those cultures. But when we have populations that are coming in from countries that we are not familiar with, as you can imagine, that gleaning gets more muddied. And so one of the things that interpreters also need is a clear understanding of how some of these illnesses present from different countries. Is there a different presentation? And that's very important to us. We don't always have access to that information. It's almost like anthropological studies. So certainly facilitating any kind of knowledge to that level would benefit us, which will benefit you, which in the long run benefits outcomes for our patients, because we're putting it in cultural context. The only other plug-in I'd like to say is that Joint Commission and really would like everyone to document the presence of the interpreter. We have a little phrase, if there's any way you can facilitate maybe downloading that phrase to all the templates you guys use on your notes. The phrase is .interpreter, and it will ask you, what's the interpreter? Where the, what modality was it? University of Rochester or Vida Remote or whatever, and then who they were interpreting for. Was it the patient or a family member? And then afterwards, that information can get aggregated in case anybody else wants to do research working with interpreters. Also, this police thing, sorry, we're like everywhere. Interpreters are everywhere. And yet we don't appear in any of your lists. So this intrigues me, this idea of shadowing. For my own personal information, I wanted to ask,
Has Rochester been, because my understanding was that they were providing some sort of training for police officers that go out to these mental health kind of arrests, and that the city of Rochester was improving the kind of education that they provide for officers. Is that something that they're still doing, or do you know?
So what I do know is, in my discussion with the senior leaders of the Rochester Police Department, it is an effort that is ongoing. And of course, the efforts of senior leadership and what actually happens on the ground are very different things. And, it's a good question. It's a good question. And I think from our residents' perspective, right, that there's always room for improvement. Right? And I think that's the message that I want to convey to everybody, that there's the more things that we can do. I think there's better responses that we can provide to our patients. And this is part of that effort to have greater collaboration between us and those members of the community that are working to bring our patients to
Right.
us.
If I can put a shameless plug in for sustainability.
Okay, on that note, we have to end. So I want to thank the residents again for a really great panel. And yeah, we'll definitely do this again. There are some more questions coming to you guys later. All right, thanks again, everybody.